The next question is, what do you think the role of tongue function and breastfeeding in pediatric sleep? So with your experience of children who are bottle fed and breastfed, and how do they sleep? A little bit of answer to this, I mean, just a little bit of history to why this question came up. So I was at the Tufts University. I'm doing my mini residency in pediatric sleep, and there was this lecture, and there's this slide that says the children who are bottle fed tend to have longer sleep. So now this really increased the question on, we know bottle feeding and the disadvantage of that, and breastfeeding and the advantage of that. But when you look at an infant and feeding, is that quantity, is that what that we always look at, or do we have to look into quality as well? What do you think is the difference in quality of sleep with children who are naturally fed with breast and formula or bottle?
Yeah, it's quality and quantity. So as I say to many parents, 4 good hours is better than 12 bad hours. So it's very important that it is a quality sleep, but you do need the quantity as well. So in infants, it's not unusual that they'll sleep for 16 to 20 hours of the day. That's all, you know, perfectly normal, and they'll wake up to have a feed and so forth, and then they'll drift off to sleep again. So it's be very hard to sort of be certain that with the breastfeeding versus the bottle feeding as to how much of a difference in the quality of the sleep is. But the suggestion or the guess would be, if the quantity has increased, it would tend to suggest that the quality has decreased, and they need longer time to make up for that decrease in the quality of their sleep. And that's clearly a bad start to the early stages of life, when their sleep patterns themselves are actually having to change to adjust for you know, the bottle feeding versus the breastfeeding.
Thank you very much. So now we do keep having these questions. Most of the parents are really worried about the quantity. So they are worried if the child doesn't sleep for 12 hours or 14 hours. What we have to really look into is the not just the quantity, but also the quality of sleep. How does, as practitioners or parents, do we know it's a good quality sleep that the child has?
Yep. So there's one question which if the answer is yes, is a major red flag to sleep. And that question is, does your child wake up tired? Because if your child wakes up tired, if the answer is yes, that is a major red flag as to what has happened through the night. Think of it like your phone, and you wake up and it's been on the charger, and you look at it, it's on 3%. You know something went wrong with the charging that night. If your child is waking up tired, something went wrong with the sleep that night. And if it's a consistent and persistent problem, then that's even more of a concern with respect to the sleep issues. So, if you want one simple question that, for parents and clinicians to answer, if I say to right now, does your child wake up tired? If the answer is yes, you have a sleep problem until proven otherwise.
So that's one thing that really gives us a red flag, where we'll have to look into more better details of how the child is sleeping.
Absolutely.
So bruxism and sleep. So this is something that's really common. My interest in our practice in terms of sleep started because we had more and more children come and complain with teeth grinding. And what we were taught in the university is teeth grinding can be related to stress, but we never learned why that stress happened in the first place. And teeth grinding can be transient. It should be all right. So teeth grinding is something that, we hear a lot, but then we are not trained enough to look deeper into. But to my understanding from your book, this is something that we need to look into. So can you please help us understand bruxism and sleep, and what are your recommendations for dentists as well as parents here?
Yeah, absolutely. So teeth grinding or bruxism, as you say, has always been put down to as stress. And it is a stress, but in children, it's a physiological rather than a psychological stress most of the time. There are some cases where it's psychological, but most of the time it's a physiological stress. And the most common cause of that physiological stress is a breathing problem that results in the oxygen levels decreasing at night. And when that happens, there's a whole sequence of events. So the child has trouble breathing, the oxygen level drops down. The brain becomes aware of this being the case, and to compensate, it makes the heart beat faster and harder. And in the process of doing that, the blood pressure goes up. When the blood pressure goes up, there's a little sensor that detects this just past the heart, that sends a message back to the brain to say the blood pressure is going too high. We need to slow the heart down and calm things down. And when it sends that message back to the heart, it also sends a message through the nerve that goes to the muscles around the jaw. So what we notice is that the oxygen levels drop down, the heart rate goes up, the blood pressure goes up, and then the teeth grinding starts. And it goes in that sequence. And we know from the science that when the ear, nose, and throat doctors help the children breathe at night, get rid of the obstruction, their oxygen levels come back to normal. About 80%, 80% of the time, that teeth grinding stops. So the teeth grinding, again, is not a diagnosis, it's a symptom. And you need to look at what it's a symptom of, and you need to make sure it's not because of a breathing problem.
Is there any diagnosis in place for us as dentists to see, to look into more about the sleep in children who have bruxism?
Yeah, so like I said, so for the bruxism, you want to make sure you don't miss a breathing or sleep problem. So again, you want to ask the questions about the mouth breathing and the snoring. The other thing that can disrupt the sleep and cause teeth grinding is having hay fever or allergies. So if the child has hay fever, sneezing, runny nose, blocked nose, which can also, of course, cause mouth breathing and snoring, that can be related to it as well. So that's another condition just outside of the mouth breathing and snoring as such that is also worth asking about. And then, again, ask the question about the tiredness, but you can also ask questions about other sleep disruptions. You can ask about sleepwalking and sleep talking and night terrors, because these are all associated with the teeth grinding too. And where it gets a little bit complicated is that these can also relate to iron deficiency. Iron deficiency can be a cause of bruxism, can be a cause of tiredness, and children that have sleep disordered breathing, because of the inflammation that within their bodies that this causes, actually causes an impairment to absorbing iron. So you have this terrible situation where the child can be tired because they can't breathe properly, and they're becoming iron deficient at the same time.
That's something to really note about nutrition and breathing. So now that this point is here, I would want to ask a couple of more questions on the role of vitamin D as well as the thyroid hormones in sleep, because I know that they're really closely interconnected. Do you want to help us understand a bit better more about it?
Yeah, absolutely. So I'll talk about the thyroid first. So the thyroid is a gland that sits in the neck, and it's particularly more relevant in adults than children as a routine. Because if the thyroid gland, for whatever reason, stops working properly, then the production of its hormone, which is called thyroid hormone, decreases. And when that happens, it results in a gaining of weight, because your metabolism drops, so your weight goes up, which is a risk factor for having breathing problems. But it also causes the muscles to reduce their strength and tone, which means that when you're breathing at night, it can collapse in and cause more problems. So it's very important, particularly in adults, to make sure that we don't miss an underactive thyroid gland as a cause of their sleep problems, because if that is the cause, then the treatment is actually to supplement the thyroid to make it work better.
So
sorry, yes?
So the point here is the dentist should also be aware about the role of nutrition in sleep. Yes. So vitamin D and...
Yeah, so vitamin D is very interesting, because when we've looked at vitamin D historically, we've always looked at the vitamin D levels in relation to a condition called rickets, which is a weakening of the bones, because we know that vitamin D is an important body hormone when it comes to bone metabolism and so forth. And if your vitamin D is low, then your bones tend to be soft and they bend. There's a condition we call rickets. So we've always focused on vitamin D levels relative to that, but what we're starting to realize is that decreased vitamin D levels may also have an impact on the immune system. And that may be relevant for dealing with viruses and so forth, like I was talking about, that potentially are causing the problems with the tonsils and the adenoids in the first place. So it's very interesting in that regard.
Thank you very much. So the next thing that I want to ask about the role of craniofacial growth in snoring, in specific a retrognathing mandible or a mandible that's a little behind than how much it usually should be.
Yeah. So we've got two important bone structures here. So we've got the top jaw and the bottom jaw, and we can get different changes. So when the bottom jaw is, which is the mandible, is sitting back, we need to realize that basically we have these attached structures. So the tongue sits within the space of the mandible bone. So if the jaw is back to where it should be in terms of its growth and development, then the position of the tongue is also further back. And then what that means is that the space between the back of the tongue to the back of the throat is potentially compromised. The other thing that can happen, though, is that the top jaw can be a problem too. The top jaw can be narrow and deficient, and it too can also be pushed back. So not only can, if it's narrow, compromise the space within the nasal cavities, but if it's pushed back, compromise the space behind the nose as well. So this is why the dentists are so important in making sure that we identify the skeletal problems, not just the soft tissue problems that the ENTs tend to focus on.
So now that I just want a little more idea or inputs on your take on extraction orthodontics. Now that we spoke about, retrognathism is something that's more alarming for the airway. So how would you explain to the audience about the role of tooth extraction and its interference with breathing and snoring or sleep disorder breathing?
Yeah, look, it's an excellent question, and I think it's a question that we need to start asking a lot more, because when, for example, we see in adults, if we go to adults as a starting point, when an adult loses most of their teeth, all of their teeth, we know that the bone structures start to become smaller, and their bones decrease in size, which we can see, quite obviously. And the concerns that I think we need to get a better understanding of is whether the removal of teeth in children, we're not talking about their primary or their so-called, baby teeth, but their adult teeth, their secondary dentition, whether the permanent removal of those teeth potentially is going to then have an impact on how the jaws are going to grow and develop, but also then in terms of how the jaws are going to stabilize. Now, some people have done some research on this, and the research does suggest that the extractions don't cause airway problems. But I don't think that everyone's really looked at the research properly, because a lot of the time when they do this research, they don't do the sleep studies, they don't do the CBCT, which are the scans of the airway. And they're not measuring the same thing. They don't get the ENT to have a look. So I think it's something that we need to have a greater focus and attention on with regards to what are the potential lifelong impacts of extracting permanent teeth with regards to bone, jaw growth and development and the airway. But I think we also need to know, at the moment the research suggests that it doesn't have a cause a problem, but we need to know what the problems with that research are so that we don't get too focused on making our minds up about what's going on.
So to my understanding, we just have one published data that says extraction. It's a retrospective data that they had presented in that particular article, which says extraction orthodontics didn't really cause
exactly
anything related to breathe. But then I'm sure there were a lot of observational biases as well.
And this is exactly right. And this is why reading the research is it's important to not just read the words, but understand how they came to that conclusion. And I think this applies to anything that we read online. Is if you're going to read anything online from a healthcare point of view, the best place to find it is in the scientific literature, not on Dr. Google searches. But when you read it, you need to realize that there's a way of reading it. It's its own special language in the way that it's written. And you've mentioned some important terms there, which the healthcare professionals would have recognized straight away as being issues, but for the parents listening at the moment would have just had no idea what we were talking about. So, for example, retrospective means looking back. So something happens and then you look back. But the problem is that when you do that, you can do what you said, which is selective, have a selection bias. And you might look back at the ones that you remember because they went really well, and you might forget about the ones that went really badly. The better way to do it is to have an intervention where you're looking at it from the beginning before you do the intervention. Take the measurements. Look at the airway before you do it. There's no good looking at the airway after you've done it because you don't know what it was like before. You might have turned a good airway into a bad airway, and then you might be comparing those bad airways to other bad airways but saying there's no difference.
Exactly.
But that's because you're choosing the wrong airways to compare.
So just concluding with this one point, we don't have enough data or the higher level of evidence that says that extraction orthodontics would not cause any airway issue at the moment, right?
At the moment, yes, but we have a big concern that it possibly does.
It does. So we do have case reports that, do you want to talk about the low level evidence of the case reports that says that this is actually causing an increase in snoring or a decrease in the airway space?
Yeah. So the concern is that the logic is very straightforward. If we're doing an intervention, extracting teeth, that we know causes a decrease in the formation of the bone structures, the question then concern is the airway is going to get somehow impacted on that as well. And extractions is usually in the context, I'm not a dentist, but the main reason for people to understand that teeth are extracted, they're extracted because they're unhealthy, so they've become decayed and they're beyond help. And from a clinical management point of view, they just need to be removed because they're going to cause a lot more problems because they are so decayed and so infected. But the other area of extraction that's probably where we're talking more so, especially in children, is in the context of where these teeth themselves are perfectly healthy. There's nothing, they're not diseased teeth, but they are in the context of having a jaw that has some development issues such that there is not enough space for the teeth. And one of the ways of treating this, which actually interestingly originated from what I understand, actually originated in Sydney, Australia, looking at the history, was actually removing the teeth to make it easier to put the rest of the teeth into a certain alignment. So that was a cosmetic approach to crooked teeth, where they could get nice straight teeth, and that was the outcome. But there was no consideration for function when that was being undertaken. So that paradigm of what we call extraction orthodontics started, from what I can tell, in around about the 1960s. And I don't think, when you sort of think about that we really have long-term results, because anyone that had teeth extracted in the 1960s, for example, for orthodontics as a child, would only at the moment be maybe 50 years old, maybe 60. So, we really don't have good evidence to know how well those people are going.